Hi everyone, this is Susan Green this time, not Rebecca, but I'm following through with the hemolytic anemias that you have been covering. Um, I'm going to present 4 slides. 2 will be MAHAs and 2 will be variant hemoglobinopathies. So let's start with this one. This one is slide 33-1A. 14-year-old female with a white cell count of 10, red cell count of 2.2, hemoglobin of 66, low hematocrit, normal MCV, MCH, and low platelets. So remember, a MAHA basically is microangiopathic hemolytic anemia, and that's due to microocclusions or some blockages in the microcapillaries or the damage to some sclerosed vessels. And by having these occlusions there, your red cells that are trying to pass through that blockage are actually being mechanically sheared into these fragments. So what we see here are fragments, or what we call schistocytes. Now Rebecca has said that they're sort of pizza-shaped. I'm trying to find one here. There's one right here. The pizza-shaped fragment or schistocyte. All of these little fragmented red cells have occurred because of a mechanical damage in that they've passed through these vessels that have been blocked and that have sheared the normal red cell into these little fragments. So you're looking for those, and of course when you have these fragmented cells that are being destroyed, that basically stimulates more red cell production in your bone marrow, because obviously it's trying to compensate for the destruction of these cells. So not only are you getting these schistocytes, you are also then getting this increased reticulocytes, like these polychromatic cells. And as you can see, there's quite a few here. That are polychromatic cells, which are your reticulocytes coming out of the bone marrow early to compensate for those red cells that are being destroyed, as well as some spherocytes coming through as well. They're in there. So we move along. There's some more there and up there. Sorry for my resolution on my computer. Hopefully this will work for you, but if you go onto Omero, you will see these for yourselves, and you can play with the brightness as well to get some decent clarity to your cells. So one more thing that's lacking is, as you can see, there are hardly any platelets. There's a largish one there, there's a platelet there, looking, another platelet there and there. But as you can see, there is a thrombocytopenia, and that goes hand in hand because they are being caught up in those occlusions in the microcapillaries. If they get to a point where there's so many caught, you'll basically get hardly any platelets coming through. And this particular count, the poor child had a platelet count of 66. Now, also remember that these little fragments can be counted as platelets, so you've got to be aware that you can have false thrombocytopenia. You can have a false count on that, so it could actually be lower than that platelet count of 66. There's another schistocyte there, another one there, another one there. You're only meant to see, if you were having fragments in your film, even seeing one per field is not a good sign. So this poor girl is not in a good place. So she has quite a few fragments that could also be counted as these platelets, as well as polychromatic cells. When they get to a point of, a lot of polychromasia, you can even see an occasional nucleated red cell, which is the orthochromatic erythroblast coming through. So that's that one for a MAHA, and she has been diagnosed with HUS, hemolytic uremic syndrome, and of course then they would be doing follow-up tests like the E. coli microbiology tests to see if she does indeed have that. Now, what also can occur with the white cells then you would get a neutrophilia with some toxic granulation. So make sure that you count your differential there as well. And in this particular case, these guys counted 68%, but there could be more. It's not a hard and fast rule that you will get the same count as what's printed in the book. So definitely do your diff and see if you get a neutrophilia with these, because they do go hand in hand with bacterial infections such as HUS. So there's that's just a smash cell. So the upshot here are schistocytes, polychromasia, some spherocytes, a possible neutrophilia, and definitely a marked a thrombocytopenia. If it's under 50, we would call it marked. Now see, we see a target cell, but that's just a minimal thing, so that obviously is not the most dominant feature in this film. You might also get a possible left shift, so left shift being band forms and occasional myelocyte. So that's that one. The other one is not as obvious. This is slide 5-7A, where the age is 58. It does say child and female, but when I look at the actual counts, I would say it's the female aged 58 is correct, with a hemoglobin of 106, so slightly under compared to the hemoglobin of 66 on the previous slide. Again, normal MCV, normal MCH, and this platelet count is 308. So a little bit more confusing, but as you can see, there are definitely fragments, such as this guy here, 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 there, there. So you can't deny that fragments are here, there, there. Just trying to see. Sorry about the resolution on this. These are a little bit more blurry. Fragment. This one's a little bit crenated. Fragment. So the fragments are there, but I can also see that these slides have got, this slide has got decent platelets. These are all little platelets. There. So by the slide itself, I think the platelet count of 308 is true. So how can I have a MAHA and a normal platelet count in this particular case? Well, there is a certain one called, because she's 58 years old as well, there could be what we have of a prosthetic heart replacement, which Rebecca had mentioned in your lecture, where they do induce a MAHA because the valve is shearing these red cells into schistocytes, but it does not affect the or activate the coag cascade or activate platelets, so you would still have normal platelets but these fragmented cells. So the one that we really would like you to remember is this guy, where there are no platelets and lots of schistocytes with polychromasia. So they're two examples of MAHA, this one being the more obvious one for you guys to learn. As I said, that has been induced by the E. coli toxin, and the poor girl has HUS. Right, so on to the next two slides. Let me pull that one up. That one is 12.1a. Now this is all about a hemolytic anemia induced by a hemoglobin variant. Now remember, hemolytic anemias, which are red cell destructive anemias, are either coming from a red cell membrane defect, an enzyme defect, or the fragmentation, as we just call the microangiopathic hemolytics, and then these guys are from your abnormal hemoglobin synthesis. So either the alpha beta globin chains haven't been produced correctly, or there's a substitution of amino acids on the beta globin chain that have produced variant hemoglobins. And in this particular case, it is the HbS or hemoglobin sickle. So HbS will produce these sickle cells, and these guys here that I'm clicking on are sickle cells. So sickle cells are produced by the polymerization of hemoglobin to the edges of the red cell. So it's an abnormal hemoglobin variant. Here we are, there's sickling there and there. And there can you see these pointy edges of the cells? And here, pointy, pointy. Here, most of these, as you can see, as they've been pulled, the hemoglobin pulls into these edges, and these projections become quite fragile. And so, let me just try and get a thinner portion of so you can see, you can move that up and it'll go to a thinner area. So when they start getting polymerized, there's not enough oxygen in that red cell, or they're in a deoxygenated state, and so they're quite fragile and quite not as soluble or malleable. They can't deform as well and go through the vessels, so they're quite rigid, and then they get destroyed as well. So here's one there, there. Now these ones were probably sickled, but then the projections have, because they are fragile, they've sort of been sheared off or destroyed. And these sickles then also, here's one there. They also get occluded into the vessels, and so you get multiple organ damage in your lung, your spleen, your kidneys, your liver, just because they cannot pass through these vessels well to oxygenate your organs. So there's some there again. If you find sickles, you immediately call it a HbS or sickle cell disease, sickle cell anemia, because they are the dominant factor in this film. You will also get then again this increase in polychromasia, poly, all these, and some targets. So polychromasia again, because the red cells are being stimulated to produce, the bone marrow is being stimulated to produce these red cells that have a defect. So it's constantly trying to produce more cells, more red cells, and hence the polychromasia coming through. There's more sickling. But if you see these sickles, then that's what your diagnosis will be: sickle cell anemia or sickle cell disease or HbS. As well as the other poiks of target cells and polychromasia. Let me go to the other one. This one's not as evident. This one here is 12.3c, HB of 96, a slight lower MCV, MCH, and RDW is high, as in the other one as well. So here I can see a sickle over here, one sickle there. There are some target cells, another sickle there. Can you see that polymerization of the hemoglobin there forming that sickle? Lots of target cells. There's a Hal Jolly body. Remember that the spleen will be basically working overtime trying to sequester the cells. There's another sickle there, target and poly. So once the spleen becomes so full, it stops working. You basically get a splenomegaly, and then you'll get more of these poikilocytes coming through to your peripheral blood, including these inclusions of Hal Jolly bodies, as well as basophilic stippling. So in this particular case, this patient had a combination of the variant, the HbS, but also a beta globin, beta thal minor, which you can't tell off the film, but you can see that these target cells, a bit of poly and some sickling, are your major features on these blood films. I hope this has helped. Oh, there's a monocyte there. If you have any questions, please go on to ED discussion board, and we're there every night. Well, I am in particular checking that board for any questions or anything that you may want to ask, and I will endeavour to answer your questions. So hopefully this has helped. Thanks.